So these are all interrelated concepts, a half, a one, and a 1.5. So what they mean by this is gaze palsy. So you heard about the supranuclear gaze palsy, where the person can't look to the left because they have a supranuclear problem on the right frontal lobe or the left parietal lobe if it's lateral smooth pursuit. So that's what a 1 is. A 1 is a gaze palsy. I can't look to the right or I can't look to the left. That's called a 1. But we don't call it a 1, we just call it horizontal gaze palsy. So the 1 is a horizontal gaze palsy. And as you remember, we talked about midbrain and pons. Sixth nerve nucleus is in pons, and third nerve nucleus is in midbrain. So 6 has to talk to contralateral 3, and that thing is called the medial longitudinal fasciculus. So in order to yoke the two muscles together, the lateral rectus and the medial rectus, to look to the left, a horizontal gaze, you have to fire at the same time the right medial rectus and the left lateral rectus. So this is a neurogenic yoke. That's what creates the Hering's law. Both nuclei are receiving the same input to make a gaze. So if you have a disruption in this interneuron, the interneuron is between two nuclei. So that thing we call internuclear ophthalmoplegia, as opposed to supranuclear, which is above the nucleus, and infranuclear, which is below the nucleus. Internuclear means between. So inter means like interstate, it's between. So internuclear ophthalmoplegia, that we call it an INO. And an INO is from disruption of the interneuron, called the medial longitudinal fasciculus, the MLF. So what that produces is a half of the gaze palsy. So if you disrupt the signal from the sixth nerve nucleus to the contralateral medial rectus muscle, the sixth nerve will still be able to fire, but the adduction will be impaired. So we've got an adduction problem plus a contralateral abducting dissociated horizontal nystagmus on gaze to the left. That's because the right MLF is causing a right internuclear ophthalmoplegia. And the most common cause of that in a young person is demyelination, and the most common demyelinating disorder is multiple sclerosis. But it doesn't have to be. It just tells you where the lesion is. It doesn't tell you why the lesion is. So in an old person, that's stroke. But in any person, it could be a tumor. So the most common acute INO in a young person is MS, demyelinating disease, medial longitudinal fasciculus. But you could have a stroke right there. An old person also causes INO. So that is internuclear ophthalmoplegia. So that's half of the gaze palsy. And because it's the interneuron, is there a way we can make the medial rectus fire where I don't need the medial longitudinal fasciculus? Can we talk directly to the third from supranuclear? What would we do to make someone fire their medial rectus with supranuclear convergence? So if we tell them, look at the tip of your nose or look at this pen, their eyes will cross in like this. And that tells you that this supranuclear input to the third nerve nucleus can overcome the internuclear deficit from the medial longitudinal fasciculus. So whenever you have an INO, the very first thing you have to do is tell them to look at their nose. Because if they can look at their nose, that means its supranuclear input to the third is intact, and that means the lesion is sparing this midbrain piece. And that means the lesion has to be in the pons. You need to know that for the test. But you also need to know that because it doesn't have to be a true INO. It could be a pseudo INO. And the most common cause of the pseudo INO is myasthenia gravis. So it just looks like an INO. They can't AD duct, but it's myasthenia. But what if you can converge? Well, that's not myasthenia. That's for sure the INO. So if the convergence can overcome the medial rectus deficit of the internuclear ophthalmoplegia, that tells you everything from the nucleus down can fire. So that is a supranuclear confirmation that the problem is an interneuron, the medial longitudinal fasciculus. Okay, so now that you know what a 1 is, a horizontal gaze palsy, if you add on a half, an INO, that thing is called 1.5. So because the sixth nerve nucleus and the parapontine reticular formation are the final common pathway for horizontal gaze, if you can't look to the left and you do the doll's head maneuver and it doesn't move the eyes, that means you're from the nucleus down. And then if you have a nucleus or a medial longitudinal fasciculus plus a nucleus, you'll get a horizontal gaze palsy in one direction, in this case to the left, plus an INO when you look to the right, because the left medial rectus can't fire because its interneuron has been damaged. So a left sixth plus a left MLF is a 1 gaze palsy and a half. A 1.5. And if the lesion's in the pons, they'll get an exotropia because the only thing that's unopposed is the lateral rectus. So it'll be like this. So the lateral rectus will fire. You've got a 1.5 syndrome. You can't adduct the ipsilateral eye. You've got a horizontal gaze palsy. That's a 1.5. And when you add on the exotropia, that thing's called a paralytic pontine exotropia. So paralytic pontine exotropia, 1.5. Horizontal gaze palsy, the 1, and an INO is a half. They're all the same problem. Interneuron and the nucleus, medial longitudinal fasciculus. So why would MLF be the most common presentation for multiple sclerosis in the efferent pathway? Because it's got to be central nervous system in multiple sclerosis. And so when you have a third nerve palsy, you could get a third nerve palsy from a central nervous system problem, but the fascicle, the part that's CNS, once it leaves the midbrain, that is peripheral now. So if it's the third nerve, or if it's the sixth nerve, you only have one shot at the sixth and the third in the fascicular portion, the central nervous system portion, to get a demyelinating event. And if it's fourth, which direction does the fourth go? Ventral or dorsal? Dorsal. So because the fourth exits dorsally, you're going to have a really hard time making an MS lesion hit just that and cause a demyelinating event for fourth nerve palsy. So for MS, fourth nerve palsy, super rare because you only get this much before it heads out dorsally. For sixth, you only get this much because it's only the pons central nervous system fascicle, same for 3. But look how many chances you have to get this if it's MLF. Pons, mid-pons, 1, 2, 3, 4, a lesion anywhere. Any demyelinating lesion anywhere between the pons and the midbrain can cause an INO. So that's what that longitudinal means. So this is longitude and this is latitude. Remember you heard about MS and the latitude that runs across our planet like this. But longitude goes like this. So this is a longitudinal fasciculus, which means you have many chances at hitting with an MS lesion or a stroke or a tumor. You see how common. And because it's the fasciculus means it's a bundle of fibers of white matter in the central nervous system. That fasciculus means MS can hit it anywhere along this course. And because it's medial, and when things are medial, you can hit both sides at the same time. And therefore, if you have a bilateral internuclear ophthalmoplegia, that's really likely to be multiple sclerosis. because it's got to be medial, longitudinal, and fasciculus. So a bilateral INO in a young person is almost always multiple sclerosis. You understand this 1.5, the half, the whole thing. So you've heard 3 different versions now: supranuclear, nuclear, infranuclear, and now inter. This is the internuclear. And we can overcome it with convergence because we can talk directly to the medial rectus. And if you can converge with an INO, that means it's not a pseudo-INO, it's not myasthenia, it's in your pons. You with me on everything I've told you? All right, we named the INO for the side of the MLF because the MLF crosses right away. And so if you have a right adduction deficit and a horizontal dissociated abducting nystagmus to the left, which side is the MLF lesion, right or left? If it's the right adduction, that's weak. That's the right. You need to know all of that. You haven't? Does that answer your question? All right. What else you got there? Next person. We have 2 days to do everything, so you guys got to come up with all the topics. Visual fields. Okay, visual fields. All right. So for visual fields, you kind of need to know the map. And without the map, you won't know where you are. Yes? So I told my daughters I'm coming to Kuwait. And the very first thing they asked me, what do you think they asked me?
Where's Kuwait?
Where's Kuwait? Because the United States State Department issued a map. And the map has red zone, you cannot go there for any reason. They have yellow zone, you can go there, but you better have a damn good reason for going there, and you have to have special permission to go there. The green zone, you can go there, but there's some places you can't go, and the blue zone. There are only 2 places in the Middle East that are blue right now. Kuwait is one. But you are surrounded.
Yeah.
Yes, we Americans, we can go to Saudi Arabia, but they will only let us travel in certain parts of Saudi Arabia. Yes, we can go to Dammam, we can go to Riyadh, we can go to Jeddah. You can't go anywhere. Iraq is the red zone. You cannot go anywhere. Iran, the red zone. Cannot go to Iran, cannot go to Iraq, cannot go to Syria, cannot go to Israel, cannot go. All red zone. Yes? There's in between ones. Qatar is in between. It's just in between. Bahrain, UAE, we can go there, but Saudi Arabia these are intermediate ones. Okay, but Kuwait, there are very few friends of America left on the planet, but Kuwait, you're still our friend. No, I'm glad to have friends. Kuwaitis are good with everybody. But, all right, so you need to know the map. You got this whole map concept? So let us draw the map of the visual field. So it looks like this. You recognize this thing?
Yes.
Okay. So if I have a lesion, this is right, this is left, in my retina, where will that look like? Where will the field defect be?
Right.
It'll be in that eye. So nothing in your eye can cause a problem in the other eye. You with me on that concept?
Yes.
In fact, anything in front of this line right here can only be ipsilateral. So if you get a lesion here, number 1, you get some kind of field defect, there better be nothing in this left eye. If the lesion is in the ganglion cell or in the nerve, you'll have an ipsilateral RAPD, a relative afferent pupil defect. So it's super important that you have to look out what an RAPD is. So if I shine a light in my right eye, what will happen to the pupil on the right? No, if I shine the light in it, it will constrict. What will the fellow eye be doing at the same time? It will also constrict. And it's equal innervation because the fiber goes to both Edinger-Westphal nucleus in the brain. If, however, I have a disparity between the right and the left eye, the right eye has a defect in its pupil pathway on the afferent side. When I shine the light on the right, it won't constrict as much. When I go to the left, what will happen to the pupil on the right? No, if I go to the left, the normal eye Both pupils will constrict. When I swing the light back from the left to the right, because the left was stronger, the right will dilate. That thing is called a relative apparent pupillary defect. You have to swing the light from the right to the left and from the left to the right. The reaction should be the same in both eyes. If you swing from the left to the right and the right pupil dilates, that's an RAPD. If you swing from the right to the left pupil dilates, that's an RAPD. So that tells you relative to the other side, there's a defect in the pupil pathway in the afferent system. It's super important that you be able to do that. Because if you're a neurologist, the only way you're going to get our attention is if you say there's an RAPD. And if you're an ophthalmologist and you look in the eye and you don't see anything and you have an RAPD, we have to call neurology. Because whatever the cause of that RAPD is, it's behind the eye. So you guys got to work together. But you meet at the RAPD. Neurology needs to know what an RAPD means, and ophthalmology needs to know what an RAPD means. For ophthalmology, an RAPD with a normal fundus means not us. Go to neurology. And for neurology, in order for us to pay attention to what you're asking us, if you write blurry vision, you get nothing. You get nothing. If you say RAPD, you have our attention. You understand what you have to say to each other? RAPD. The magic word is not please. It is RAPD. Doesn't matter whether you're ophthalmologist or neurologist. All right, now, as yeah.
Call the ophthalmologist, then we will come.
What's that?
They usually say call the ophthalmologist, then we will come.
Yeah, in my hospital, if you say call the ophthalmologist, what you really are going to get is when our clinic is done and when we feel like it, we'll come over. That is our hospital. Because we have full clinic. We have operating room. We cannot just leave the OR just because you want us to come there. We cannot do it. All right. As we're getting closer and closer to the chiasm, the fibers are going to move. So inside your eye, the fibers respect the horizontal or the vertical meridian. Inside your eye. The horizontal. So the fibers go around like this. So these are nasal, this is temporal. So the temporal fiber goes all the way around the fovea and inserts to the top of the disc. And the inferior fiber goes all the way around, inserts to the bottom of the disc. What are we trying to avoid in the center there? Why don't the fibers just go straight across? Can't go in your macula. So we want the fibers to go around this X. So we're trying to go around the X. So that means the fibers in the eye respect the horizontal meridian. So all the things that damage the inside of the eye. And what's our most common cause of a field defect in the eye, ophthalmologist, the whole world? Glaucoma. So you need to be able to tell if it's glaucoma or not glaucoma. Glaucoma, horizontal meridian, nasal step, and cupping. We can literally look in the eye and tell if it's glaucoma. But if we look in the eye and it's not cupped, or the field is too much, or it's vertical rather than horizontal, we're calling you. Because that means it's not glaucoma. Even though glaucoma is millions of people. So, as you're getting closer and closer to the chiasm, the nasal fiber is trying to do what? Decussate. So inside the eye, horizontal. As you get closer to the chiasm, nasal fiber is trying to decussate, cross, and temporal fiber, not cross. Inside eye, inside brain. Inside eye, inside brain. Yes? You got this whole map thing down. Because when I told my kids I was coming to Kuwait, they're like, isn't that next to Basra? But weirdly, Basra is the yellow zone. So Americans, especially from Houston, Texas, our number one business in Houston is your number one business, oil and gas. You know how many Texans are coming to Kuwait all the time, every day. Yeah. Oh, by the way, my town, Houston, Texas, has 7 million people.
Down?
Houston, Texas by itself would be the number 23 economy in the whole world. Just our city alone. Our economies are tied together, by the way. Houston, Texas. When the price of oil goes up, it helps you, it helps us. Yes? If stuff happens over here, it affects me in Houston, Texas. When the bombs hit in Qatar, it affects me. Yes? If anything disrupts that shipping lane, it affects you, it affects me too. That's weird. Yeah, oil and gas is our number one business. Our number two business, however, is healthcare. Our number three is space exploration. All right, you got this nasal crossing fiber. You see how that nasal fiber crosses? Is it equal crossing? No. What's the crossing ratio in the chiasm? 53, 47. Okay, so more fibers are crossing. And what that means is, even though the field is drawn as a circle like this, it's really an oval. So who is bigger, your temporal field or your nasal field? Your temporal field is bigger. That's going to become important in a little bit, okay? So even though it's drawn as a circle, your field is not a circle. It's an oval. The nasal field is smaller. The temporal field is bigger. So put your finger out here and look at, you're not doing it. I can see it. Okay. If you close this eye, what happens to the finger? It's gone. If you open it, so that means this left eye cannot see over here. You have binocular vision from here to here. But as soon as you're out here in the way temporal, that's only monocular. The right eye only sees this extreme portion of your temporal field. You got that? Temporal field bigger. Nasal field cannot go all the way over here. You got that whole concept? All right. So if you have a lesion that's close enough to the optic nerve and the chiasm, at the junction of the optic nerve and the chiasm, there's two weird things that can happen right there. The first is you can have a field defect in this eye, but because it's affecting the crossing nasal fiber of the other eye, it'll cause a superior temporal field defect in the fellow. The name of that thing is called a junctional scotoma. It's a junctional scotoma because it's at the junction of the optic nerve and chiasm. And that's because if you're close enough to the chiasm, you'll not only get an ipsilateral optic neuropathy, you'll damage the contralateral nasal crossing fiber. You with me on this whole concept of at the junction, you can damage both the ipsilateral nerve and the contralateral crossing nasal fiber, causing a superior temporal field defect in the fellow eye. That's super important to know because 20-year-old female, acute unilateral loss of vision, RAPD, normal fundus, field defect in the involved eye. What's the most likely diagnosis? 20-year-old female, acute unilateral loss of vision, RAPD, normal fundus. Optic neuritis. However, if we test the other eye and there's a superior temporal field defect in the fellow eye, that lesion is right there. And that lesion's called junctional scotoma. And 95% of the time, a tumor is right there. So you literally just change the diagnosis from optic neuritis to a tumor. Why would a tumor at that location present acutely with pain? What's the name of that tumor when it's like all of a sudden it's at the chiasm? Apoplexy. Pituitary apoplexy. So in the optic neuritis treatment trial, there were 2 patients accidentally enrolled into the optic neuritis trial in the United States who actually didn't have MS. One of them was pituitary apoplexy. The other was ophthalmic artery aneurysm. So if you have a junctional scotoma, that's a compressive lesion at the junction of the optic nerve and chiasm, 95% of the time. Because most optic neuritis is like intraorbital enhancement. That's like most of the cases of optic neuritis. Once you put the lesion right here at the junction, that's a tumor. And a tumor can present acutely. So meningioma, it wouldn't present acutely. It would be slow. And that one, you would know that's not optic neuritis because they didn't get better. So the junctional scotoma needs an MRI. But in the acute setting, make sure it's not apoplexy. And you have to have an MRA in the acute setting because you need an A to find that A ophthalmic artery. You with me on this junctional scotoma? Okay, there's this other junctional field defect. The other junctional field defect is when it's only half, one eye only. So if it's only one eye, it's only caused the nasal crossing fiber. So if you have a lesion right here pressing on the crossing fiber, it only causes a monocular temporal field. So this thing is also a junctional scotoma, but it's called the junctional scotoma of Traquair. It's a different kind of junctional scotoma. So both the junctional scotoma and ipsilateral optic neuropathy plus the contralateral superior temporal field defect, or the junctional scotoma of Traquair, a monocular hemianoptic field defect, usually temporal, they're both tumors. And you have to scan them. And you have to scan it today. So in your public system, optic neuritis may not get the scan today. But if it's the junctional scotoma or the junctional scotoma of Traquair, you cannot let the sun set on that. That could be ophthalmic artery aneurysm or pituitary apoplexy. And if it's apoplexy, you kind of need your pituitary. You'll die without cortisol. So do not fool around with the junctional scotoma or the junctional scotoma of Traquair. Those are tumors or aneurysms until proven otherwise. You understand how dangerous this thing is. All right, ophthalmologists. The person has this, and their count fingers. Should we test the other eye? What will the patient say when you try and tell them to do a field on their good eye? This is a good eye. Why are you? You're just trying to rob me of my money. No, man, you have to test the other eye, okay? You have to test the good eye. So if I ask my resident, hey, where's the field? They're like, Dr. Lee, the person's hand motion. They wouldn't be able to do a field. The Humphrey will be completely black. They won't see anything. I'm like, not that eye, you dummy. Other eye. What are you looking for in the other eye? What's the name of that field defect?
Junction.
It's called that because the lesion is at the junction of the optic nerve and chiasm. Do not let the sun set on junctional scotoma or junctional scotoma of Traquair. If it's ophthalmic artery aneurysm, that thing is going to rupture because it's a symptomatic aneurysm. And that if it ruptures, half the people die. Don't be fooling around with no junctional scotoma or junctional scotoma of Traquair. Okay, this number 3 one is so easy. What does it produce when it's at the body of the chiasm? So easy, yes. Bitemporal hemianopsia. Yes? All right. You guys believe in the Old Testament here, yes? You have 20 of your books, just like us? Yes? In the Bible, in the Old Testament, David is called upon to fight against Goliath. Who is Goliath? You know Goliath? You don't know this story. Who knows this story? He hit him with a slingshot. So the Goliath, he's a giant. He'd never been defeated in battle. In the Bible, it says he's 7 feet tall, maybe 7'4", something like that. Okay, a boy hits him with a slingshot and kills him with his own sword. All right, what was the diagnosis? What was the field defect? What was the cause? Ophthalmology. That's it. That's all you get. A boy fought against a giant, David and Goliath. It's the most famous boy beats giant story in the whole world. Why does he have a bitemporal? Yeah, that's why he couldn't see the rock. Why is he a bitemporal? What is the tumor producing? Growth hormone. That's why he's a temporal. Yes? So, the diagnosis of Goliath is gigantism. He is a giant because he has a pituitary adenoma, which is secreting growth hormone. That's why he's a giant. He has a bitemporal hemianopsia. He cannot be killed straight on with the weapon that was used on him, slingshot. But not this kind of slingshot. It was like this. So the rock is flying like this. And the guy talking, he hits him in the side of the head, he falls down, and David kills him.
David was the ophthalmologist.
Well, that's the joke, right? In the Bible, it says David had the hand of God, but maybe he had the hand of Neuro Ophthalmology. All right, so in this chiasm, the crossing fiber right here causes this kind of bitemporal hemianopsia, a paracentral. So you should know that the macular fiber crosses in the most posterior portion of the chiasm. So a bitemporal paracentral is posterior chiasm. You got this posterior chiasm. All right, if you have a lesion here, number 4, what will it produce if this is the right side? Because you're involving the uncrossed temporal fiber and the crossing nasal fiber. Homonymous hemianopsia. And That homonymous hemianopsia will be on the right or the left if it's a right-sided optic tract. And it's going to be incongruous. So an incongruous left homonymous hemianopsia from a right optic tract lesion. Now, I told you which field is bigger, the temporal or the nasal fiber?
Temporal.
Yeah, the temporal field is bigger, and that's because the nasal fiber is bigger, and the nasal fiber is bigger because there's more crossing because the temporal field is bigger. And therefore, there's going to be an RAPD relative to the fellow eye. Which eye will have the RAPD in a right optic tract lesion? So right optic tract produced left homonymous hemianopsia. Which has the bigger field defect, the eye with the nasal or the eye with the temporal field defect? The temporal field. And which eye is that in a left homonymous hemianopsia from a right optic tract lesion?
The right.
Is it left or right?
Left.
Left hemianopia.
Right optic tract, left homonymous hemianopsia. Which eye has the temporal field defect?
Right.
Is it the right eye or the left eye that has it? Okay, which is it, right or left? Left. Which eye is going to have the RAPD? Left. So even though the lesion is on the right side, the RAPD in a tract lesion is on the other side because that was the nasal or temporal fiber. Nasal fiber is temporal or nasal field. Temporal field is bigger or smaller than nasal field? Okay, temporal field is bigger. It's bigger by exactly this much. Put your finger there. You saw how much bigger it is, yes? The temporal field is bigger than the nasal field. The temporal field is the nasal fiber. The nasal fiber is 53% of the chiasm. It's crossing because the temporal field is bigger. And therefore, if you have a right optic tract lesion, which eye will have the RAPD relative apparent defect, who actually has more field defect? The left eye. However, if I swing this light in the clinic, and they have a left RAPD, and I ask my resident or ask my medical student which side is the lesion on, what will they say if the person has a left RAPD? They'll say the left. And I'll say no, and I'll say look at it again, and then what will they say? They'll switch sides. I'll say that's wrong also, yes? So, which eye has the RAPD in a tract lesion? Is it right eye, left eye, neither both? In a right optic tract. Left eye. And that means if you have a left RAPD, the lesion could be on either side. It could be on the left side if it's in front of the chiasm, ipsilateral. But if it's the tract, it'll be on the other side. So when you have a left RAPD, the lesion could be on the right or the left. It's on the right if it's post-chiasmal. It's on the left if it's pre-chiasmal. You with me on this RAPD? Which field is bigger, nasal or temporal?
Temporal.
Temporal. Which eye has the RAPD in a right optic tract, right or left?
Left.
Pick.
Left.
Left. How about if I'm pre-chiasmal and I have a
Right.
left RAPD? Left. Left eye or left optic. So it's ipsilateral RAPD if you're in front of the chiasm. If you're behind the chiasm in the tract, it'll be on the contralateral side. Yes? You got all that?
Yes.
Okay. Because the cell body lives here. What's the name of this thing? This collection of the cell body from this axon. The lateral geniculate body. In the lateral geniculate body is the cell body. Any lesion that disrupts the axon from its cell body all the way to its original cell body will cause optic atrophy. What's the name of this degeneration? What's the name of this axonal degeneration? You know, you got this axon and it got damaged. It'll degenerate. Yes? It'll go retrograde and anterograde. What is the name of this degeneration? Dead dude's name. Wallerian. Wallerian. You heard that word before?
Yes.
So, if you cut an axon in the central nervous system, it'll die. That's sad, don't you think? In the peripheral nervous system, it'll regrow. But in the central nervous system, once you cut it, game over. He'll try and go back, but it won't. So it can die back, retrograde. It can die forward, anterograde. And that is what makes neuro ophthalmology. Because we can literally look in this eye and see optic atrophy, and you have brain tumor. We can look in people's eyes and see that the axon has been disrupted by looking in people's eyes. Don't you think that's a superpower? At the break, some people ask me, why did I do neuro? We have a superpower. We can literally look in people's eyes and defeat Goliath. Yes? You want to have a superpower. David was a boy with a stick. Goliath had never been beaten in battle. Till that day. All right, the optic atrophy. It's a special type of optic atrophy. Remember I told you the temporal fiber goes all the way around and inserts right into the top of the nerve. And then temporal fiber from the below comes up like this. And that means in the eye, which one's the temporal fiber? Up and also down. And these are nasal fibers. And so when we have damage in the temporal field, that is which fiber? Nasal or temporal? Nasal fiber. And so if I have a bitemporal hemianopsia, it'll make optic atrophy because of that degeneration. What's the name of that degeneration? Malarian degeneration. And that means even though the tumor is way inside of their head, neuro can look in people's eyes and see the tumor. No MRI. All right, what will be the atrophy then? If it's temporal fiber? Nasal atrophy. What is the name of this nasal atrophy when it goes like a band or looks like a bow tie on your nerve? What's the name of this? Band atrophy. You heard that word before? Band. Band. Also looks like a bow tie. You see bow tie? You see it there? Yes. So the temporal fiber is at the top and the bottom. It's at the top and the bottom because the temporal fiber has to go around the fovea, right to the top, to the bottom like this, and this like nasal. Yes, nasal, nasal, nasal. If we see band atrophy, it's a tumor. Superpower. All right, the band atrophy and a bitemporal hemianopsia will be in both eyes because both eyes have a temporal field defect. Temporal field is which fiber?
Nasal.
I heard you guys have a soccer team. Yeah, what's the name of your soccer team?
Kuwait.
What's it?
Kuwait.
Yeah, but what's Kuwait? What? Like our team is Houston Dynamo. That's our team. You don't have that. You just say we're Kuwait. That's our team.
These are clubs.
You don't have no mascot. You don't have
No, the Kuwait national team, the mascot is a camel.
camel.
Yeah.
All right, so you understand this bow tie atrophy? Okay, if you got that, then the tract lesion. Okay, right optic tract produces what type of field defect? Left homonymous. There'll be an RAPD. Which eye has the RAPD? The contralateral eye, right optic tract, left RAPD. Which eye has the temporal field defect in a right optic tract? The left. And which eye has the band atrophy? The right or the left? No, in a left homonymous hemianopsia, only one eye has the band. Because only one eye has the temporal field. And the temporal field is the nasal fiber. So which eye in a right optic tract lesion has the band atrophy? The left. Because the left eye has the temporal field, which is the nasal fiber. Yes? So one eye has the band, the other eye just has the two stuff together. So in a right optic tract lesion, the band atrophy will be in which eye, the right or left? If it's a right optic tract, left eye. Which eye has the RAPD? The left eye. In a bitemporal hemianopsia, however, no RAPD. How come? Both eyes have band. It's equal, canceled out. But which eye has the band? Both. So in a number 3 lesion, both eyes have the band, bitemporal hemianopsia, no RAPD. In the right optic tract, left homonymous hemianopsia, left band, left RAPD. You understand everything I've told you? These are very common test questions. Very common. Okay, anything behind here is going to cause homonymous hemianopsia. But you need to know there's something different about the geniculate body's blood supply. Who wants to tell me what the blood supply is of the geniculate? Alan Maurice. Anterior choroidal and what's the other choroidal? Yeah. Yeah. So there's a lateral posterior choroidal artery and an anterior choroidal artery in the geniculate body. And what that means is the geniculate body has a differential blood supply that spares or involves different layers of the geniculate. So the geniculate has all these like layers like this, lateral geniculate body. But because the blood supply is a top and a bottom and a central, you get a weird looking visual field defect in geniculate lesions. So in geniculate lesions, it looks like Pac-Man. So either it goes like a wedge to fixation, or it spares that wedge. So it can look like the opposite. Looks like so a field defect that either spares or involves that wedge to fixation is geniculate. If it's sparing this anterior thing here, that's the anterior choroidal artery. This one's the lateral posterior choroidal artery. You need to know this for the test. So if you see sparing or involvement of this wedge in a homonymous fashion, pick geniculate body. Because the blood supply is top and bottom, middle spared, or middle involved, top and bottom spared. That is the unique blood supply of the geniculate body. So even though it is homonymous, this sparing or involvement of this wedge to fixation, pick genic. Anything behind the geniculate body will produce homonymous hemianopsia. However, in your temporal lobe, the fibers are going from the geniculate like this to the occipital. So what's the name of that loop in the temporal lobe? Myers loop. Is that the superior or inferior fiber?
Superior. No, it's superior visual field.
It's superior visual field because it's the inferior fiber. So the temporal lobe is below it's down here. Temporal lobe is inferior fiber. The name of that fiber is Myers loop, and that causes pie in the sky visual field defect. So pie in the sky. Because the homonymous hemianopsia is denser superiorly. So in your brain, any lesion that is in the superior pathway causes inferior loss. So if it's a superior retinal detachment, what will be the field defect? Inferior field. If it's Myers loop, which is the inferior fiber, the inferior radiation, it'll cause pie in the homonymous hemianopsia on the ipsilateral or contralateral side. Contralateral side. And if you are in front of this line, you'll get optic atrophy. What's the name of that optic atrophy? Band atrophy. And you'll have an RAPD. But if you're in the Myers loop, which eye has the RAPD?
No,
No RAPD. How come?
it's past there.
Because the pupil fiber already left.
Yeah.
So here's the nerve, here's the geniculate. The pupil fiber comes off right here at the optic tract. To go to the Edinger Westphal nucleus. So if you have a lesion in the temporal lobe, which eye has the RAPD? Right, left, either, neither, both. Neither. If your lesion is in the parietal lobe, which eye has the RAPD? Neither. If it's in the occipital lobe?
Neither.
So any lesion behind the tract, no RAPD because there's no pupil there. The pupil fiber leaves the tract. So the only place you can get a homonymous and an RAPD is the optic tract. That's the only place. Any lesion in front of this chiasm would produce ipsilateral RAPD. Any lesion behind produces homonymous hemianopsia. How about the optic atrophy? Will there be optic atrophy in a pie in the sky homonymous hemianopsia from temporal lobe? Yes or no? No, because the cell body lives in the geniculate body, and any lesion behind the geniculate body, no more cell body, no more wall area. Now there is transsynaptic degeneration, but we can't see it clinically. So if you have optic atrophy, that's geniculate or anterior. You understand what I've said? The optic atrophy means we are in front of this geniculate body. How about occipital lobe? Will that have optic atrophy? Nope. Parietal lobe? Nope. Temporal lobe? Nope. So the only place you can have band atrophy and RAPD in a homonymous is only one place. Tract. You need to know the defining features of the optic tract syndrome because 95% of the time a tract lesion is a tumor. It's just so hard to get a stroke there, or trauma, or demyelination. It's just not common. It's a tumor. It's super important that you know that the tract syndrome has an RAPD and optic atrophy. The name of the optic atrophy is band atrophy. Band atrophy is nasal or temporal fiber. Nasal fiber is that nasal or temporal field. Temporal field. So if we see any respect of the vertical meridian that's in your brain, and it starts at the junctional scotoma of trochlear, it goes to the body of the chiasm, the posterior chiasm, the tract, the geniculate, the retrogeniculate, any respect of vertical is bad. Okay, and the reverse for the superior fiber in the parietal lobe, that causes field defect pie on the floor instead of pie in the sky. Superior fiber, inferior field. And in the occipital cortex, we have these two extra things we got to worry about in the occipital cortex. What are the two extra things we got to worry about? One is sparing of the tip. What is the name of that sparing? Macular sparing. So in the occipital cortex, this right here, this tip, is where your fovea is. And because we have a dual blood supply to this space right here, somebody thought it was really important. This occipital tip is often spared. And so when you have occipital lesion, it might spare the macula, but not like the wedge of the geniculate body, just like 5 degrees. So that is called macular sparing. Macular sparing. If, however, it just split down the middle, that thing is called macular splitting. The macular sparing means you spared this tip. Tip sparing. Because the tip is where the fovea is. Dual blood supply, also large representation there. So when we're doing a field, if we see macular sparing, that's a sign that it's occipital. If we see macular splitting, it doesn't help. So it only localizes if it's macular sparing.
Is there any way to test for macular sparing clinically on its own? That's a visual field test.
You can try, but you need the field, a real field. So when you guys, if you're a neurologist and you're doing confrontation field, the best you're going to be able to do is like, okay, it's homonymous or bitemporal. That's really the best. You might be able to get its denser superiorly or inferiorly, but really we have machines that do it way better. Same thing for looking in the eye for band. The machine just sees it way better. Ophthalmologists, tell them what the name of that machine is. OCT. So OCT sees better than me. Optical coherence tomography, it can literally show band atrophy, even though I didn't see it. The machine can see the band, and it's color-coded. Right, guys? Green is good, yellow is borderline, red zone all the way across there. So the band atrophy, the machine can see what we cannot. So if you're an ophthalmologist, you need to be able to recognize band. The red zone goes all the way across. And occipital sparing. Okay, the last thing you need to know about the occipital cortex is it's going to be very congruous. Congruous means the field defect is the same in each eye. And the reason is, in radiation lesions, the fibers are radiating out like this, like half are going upstairs and half are going downstairs. It's super hard for things that are radiating out to make the exact same field defect in both eyes. And that's incongruous. But as it's getting closer and closer to the occipital cortex, the radiations are like getting really, really tightly packed like this. And so when you get a lesion in the occipital cortex, it makes a field defect that is very congruous. Like it looks exactly the same. Like you can take a picture of it and punch it out and paste it in the other side. So even if it's pie in the sky, what you're looking for is macular sparing and congruity. And if it's pie in the sky and there's an RAPD, that's tracked. And if it's pie in the sky and there's band atrophy, that's tracked. So pie in the sky by itself does not tell you it's temporal lobe. That could be occipital. You're looking for macular sparing and congruity, or it could be temporal. But the way they teach it to you, it makes it seem like pie in the sky, and that's temporal for sure. You don't know. Congruity, macular sparing, and then there's one last thing, which is this temporal crescent sparing. You remember that guy, the temporal crescent? I just drew these all as circles, but they're not. So in the eye with the temporal field defect, that will be spared sometimes in occipital. And that thing is represented in the most anterior portion of the calcarean cortex. In the most anterior portion of the occipital cortex, that represents the crossing nasal fiber producing a temporal field. And that thing's called the temporal crescent. Temporal crescent. Crescent. Temporal crescent. So it's way out here. Okay, it's temporal crescent. You remember that thing? You put your finger there, you can't see it. That is represented in your other cortex. So a right temporal crescent is actually left mesial anterior. So how would you test for this? Because ophthalmologists, how big is our field test on the Humphrey? How many degrees is it? 30 or 24. It will not detect this. So you get this kind of field defect, you get this homonymous hemianopsia, we're going to test in the temporal field. That is where you could use the finger. So ophthalmology sends you this patient. They have a left homonymous hemianopsia. We're only testing the central 30 or 24 degrees. And you're going to take your finger and put it into the temporal field. And you're going to start in the middle. And you're going to close one eye. So you're just testing the temporal field. So you say, can you see the finger? No, 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 no. Yes. As soon as they say the yes in the temporal field, occipital. Do you understand what I've said? Mm-hmm. So sparing or involvement of just that temporal crescent is occipital. Because that occipital is a temporal crescent represented in the most anterior portion of the contralateral occipital cortex. You got all this? For an ophthalmologist, if the person just comes in and they say, I have this crescent over here, this eye's normal. Say, you do a 30-2, what's it going to be if it's just the temporal crescent? Completely normal, because you're only testing the central 30 degrees. But they're insisting that something's wrong with them because it's in their cortex. Will they have an RAPD? No. What will their fundus show? Normal. What was their acuity? Normal, 6'6", 20/20. So this person who's 20/20, 6'6", has no RAPD, has a normal Humphrey visual field. What will their OCT show? Normal. And you're going to tell the person they're faking when they have a lesion right here. Don't do that. Yes? So they say, look, my field defect is out here. You say, how far out there? Way out here. Okay, just show me where it is. No, I see yes, 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 no. Yes, 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 no. Yes, 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 no. It's out here like this temporal crescent? Yeah. Which side is that on? If it's a left temporal crescent, right or left? Right. That's correct. However, if we see an RAPD, that's a retinal detachment. Is it going to be nasal or temporal detachment? If it's temporal crescent, You gotta dilate their eye and look in the fundus. But if you see it's retinoschisis or detachment, you're done. Don't send that to neurology. Don't scan that. The one you have to send to neurology and the one you have to scan is the one with nothing in their eye. So weirdly, the nothing in the eye is a very dangerous thing. Temporal crescent, nothing in the eye, no RAPD, normal acuity, normal OCT. You're going to be tempted to say that person's fake. Don't do that. That person is not fake. Okay, lesion is right there. You guys have any questions about what I've told you about visual field? Yes.
Can you talk about altitudinal visual field defects?
Okay, altitudinal. Altitudinal usually means it's in your eye. But if a lesion is pressing right here at number 1 in the ipsilateral optic nerve, it can make altitudinal. So our most common cause of altitudinal field defect in the eye is what? Ophthalmology?
NAIO.
NAION in the acute setting, you better see a swollen nerve. And the pallor of the nerve, if it's a superior altitudinal, where will the pallor be? Inferior or superior? If it's a inferior altitudinal.
Superior.
Superior. So if we see superior swelling, small cup to disc ratio, vasculopathic patient, acute unilateral loss of vision, that's NAION. We don't scan that. We don't do anything for that. That's blood pressure, blood sugar, cholesterol, exercise, no smoking, aspirin. That is our most common acute. What's our most common chronic cause of an altitudinal field defect? In glaucoma. And we can see that one too, because that one's going to cause cupping. And the cupping is going to cause a vertical notch. Is the notch going to be inferior or superior if it's in the inferior altitudinal field defect? So they better have a superior notch with cupping, glaucoma, if it's inferior altitudinal. If it's chronic, glaucoma. If it's acute, NAION, but we better see the swelling. What if they come in, there's no cupping? It's just pallor. You have to scan that. Because now the lesion is here at number 1. And is the tumor pressing from above or below if it's an inferior altitudinal field defect? If it's inferior altitudinal, is it pressing superior or inferior? Superior. And if it's pressing from above, that's almost always meningeal. If it's pressing from below, pituitary, no. Because pituitary under, meningioma on top. So inferior altitudinal does not tell us what it is. It tells us where it is. Anywhere from the junction to the eye. Now you do have to rely on ophthalmology. In the acute setting, if the nerve is swollen, NAION in an old person with vasculopath. If they're young, optic neuritis. If it's cupped, glaucoma. What if the fundus is normal? That's back to neurology. That you guys know. Yes? That means it's behind the eye, but before the junction. Most common cause in a young person, optic neuritis. You got all this visual field stuff down? So it's just another example of location. Inferior altitudinal, it tells you where the problem is, not why the problem is. Tell me where. Guys got this whole field thing down? All right, next thing. The car's coming at 2. What do you guys got?
No, but the OC test, like, if it not the vertical engine, it's neurological cause. It's not glaucoma, but superior altitudinal. Sometimes it's tumor.
That's exactly what I'm telling you.
So you don't.
You cannot use that field to say that it's not a tumor. Inferior altitudinal could be glaucoma. You better see cupping. And it better match the field. Inferior altitudinal, that could be NAION. You better have disc edema. You better see the disc edema. You better have sector pallor afterwards. You better be a vasculopath. What if they're too young? Or they don't have any risk factor? Or it's not cupping? You got to scan them. So, when should you scan an inferior altitudinal? Isn't that what you're asking me? You should scan an inferior altitudinal if you didn't see the disc edema and NAION. if you don't have a match on the cupping? What if you have no cupping? You just have atrophy. You have to scan it. And the scan is going to be MR, head, orbit, gadolinium fat suppression, because you have to scan both the intraorbital portion and the intracranial portion. The most common reason an ophthalmologist would miss a brain tumor is they didn't order the right scan. They ordered an MR of the brain, no contrast. Or they did an MR of the orbit, no brain. Or they did an MR of the orbit, no fat suppression. So you need to have MR, head and orbit, gadolinium fat suppression. This is our optic nerve protocol imaging study. We're going to say it together so you remember it. What is the MR that we need? MR, head, orbit, gadolinium fat set. Are you ready? What MR do we need? That was terrible. What imaging study do we need? MR, head, orbit, gadolinium fat suppression. You need to have that. MR, head, orbit, gadolinium fat suppression. Who wouldn't do the orbit? Neurology. In my hospital, never orders the orbit.
We do order.
However, if you're in the stroke service, they no contrast. So it's going to be MR head and no orbit and then no contrast. That is our standard stroke
It's
scan
always
protocol.
I
It's just
noticed
the normal.
the MR head orbit, like the fat suppression as well. It's a lot of the time we focus like time of flight or other stuff, but
Yeah, you have to write every single word there. MR head orbit gadolinium fat suppression. MR head orbit gadolinium fat suppression. What if you don't write all that? They don't do it. You have to order all the pieces. Okay, head orbit gadolinium fat suppression. Tell me again, what do you need? Head orbit gadolinium fat suppression. Head orbit gadolinium fat suppression. Okay. All right. What else you got there?
Skew deviation.
Skew deviation. Okay. All right. Skew means your eyes are skewed. The skew deviation is a vertical deviation that cannot be better explained by a single muscle or nerve distribution and is due to a posterior fossil lesion. So it's defined by what it's not, okay? Because there are no diagnostic features of skew. I'm just going to say it again. There's no, I did these tests and it is skew. There's only, I did these tests and it's compatible with skew. Could it be myasthenia?
Yes.
Yes. Can you myasthenia make your eyes go askew?
Yes.
Thyroid?
Yes.
Okay. So skew means it's not myasthenia, not thyroid eye disease. It's like what it's not. It has to be a vertical deviation that cannot be explained by something else, and it has to be a posterior fossil lesion. That's a weird definition, don't you think? Shouldn't it be if it's right hypertropia, worse than right gaze and right tilt, that's skew? That's not, there's no such thing. Okay. So before you can understand skew, you have to understand three-step test. So ophthalmologist is going to help us with the three-step test. Who wants to volunteer to help the neurologist with the three-step test? Yeah.
So if he has a right hypertropia, for example, he will have a left hypertropia.
So right
In
hypertrophy.
primary case.
So the first step in the three-step test is which eye is higher. By convention, we name the deviation for the higher eye. However, a right hypertropia is the same thing as a left hypotropia. They're the same thing. But by convention, ophthalmologists name hypers for the higher eye, right hypertropia. But you should know it could definitely be the left eye that's the problem. Okay, if it's the right eye, that's high. 4 muscles could be weak. This is right and this is left. So what are the 4 muscles that could be weak? But you have to show every step of the way, okay? If the right eye is high, that means the depressors of the right eye could be weak. There are 2 depressors.
We have the superior oblique.
The right superior oblique and the right inferior rectus. But it could be that the the left eye is hypotropic, the left eye is low. That means the elevators of the left eye can be weak. The left superior rectus, the left inferior oblique. So that's the first weird thing you need to know. The superior oblique is a depressor, and the inferior oblique is an elevator, even though it says superior and inferior, which is the opposite. And the reason that is because the superior oblique and the inferior oblique are very weird looking muscles. So the superior oblique, it looks like this. Its origin is way back here, but the effective origin is right here. What is the name of this tendon? Trochlea. So the trochlea of the superior oblique is here. It's medial, and it's oblique, and it's superior. It's on top of your eye, superior, but it's obliquely inserted. And what is the angle of this insertion? 45. Is it 45? What do you guys think? Okay, Google. Okay, 23. So it's 23 and me. Okay. So this is 90. This is 180. You got the degree thing. This is 45. It's 23. Okay. So here we go. Because it's superior and obliquely inserted, when this muscle fires, its primary action is intorsion, like this. See here, fire, intorsion. However, when I go into adduction, what does its primary action become? Depressor. And when it's abducted, it can only intort and abduct. So this we call the primary, the secondary, and the tertiary action of these muscles. So the medial and the lateral rectus is so easy. It can only do one thing. Abduct, adduct, that's all it can do. But the superior oblique, because it's superior and inserts behind the equator and it's this weird angle, it intorts in primary. That's its main job. But in adduction, when it's in this position right here, adducted, it becomes a better depressor. You see how it's a better depressor in adduction because the cornea and the muscle belly are lined up. And so it's a better depressor. When it's abducted, it can't depress anymore because you have a 90-degree angle now for the muscle. And so it can only abduct and intort in abduction. And that's why when we draw this little H diagram, the obliques are put in this adducted position because they work better vertically when they're in the adducted position. You with me on this adduction thing? And when they're in the abducted position, the rectus muscles work better for up and down. Notice that we're not even including the medial or lateral rectus because this is a hypertropia. So it doesn't involve the side-to-side movement at all. It's only the pitch plane up and down. All right, so you got the four muscles here. Yes? You got how he got those four muscles?
Yes.
Okay, what's the second step?
Right gaze, left gaze. Check the.
All right, so this person's worse in left gaze. So this is left and this is right. So when they look to the left, two of these muscles work better when we look to the left. Which two?
The right superior oblique and the
Because he's down and in like this.
left superior oblique.
Because he looks up and out like that. So because it's worse on gaze to the left, the two muscles that look to the right are no longer in play. Yes?
Yes.
Do you have like tournament for your soccer team? It's like 4 teams and 2 teams, and then someone's the champion. 3 steps. Takes 3 games to get there. Yes? To get the league champion. All right, so it's down to these 2 muscles now. Second step.
Enter the left and enter.
So in this case, tilt to the right makes it worse. So remember I told you when you tilt your head to the right, the semicircular canals fire, the vestibular ocular reflex to counterroll the eyes like this. But you know now that the primary action of the superior oblique is what? Intorsion. And the superior rectus also is obliquely inserted. 23 and it also has torsion. What is its torsion? The superior muscles, are they intorters or
All superior. All
They're
superior.
both intorters. And so now we have tilt to the right made me worse. So when I tilt my head to the right eye has to intort or extort. And the left eye has to intort or extort. Extort. But we only have 2 choices in the championship game, and they are both
Into.
they're both intorters. So who wins? the championship. If it's a right intorter that's weak or a left extorter, if I'm down to right superior oblique versus left superior rectus, which are both intorters, the right superior oblique, because this guy is intorter of left eye. Champion, quick. Yes? This is the three-step test. So a right hypertropia, worsened left gaze, and right tilt implicates the right superior oblique, which is a fourth nerve palsy. So if you do the three-step test and it's worse on tilt to the left, or it was worse on gaze to the right, those are going to produce the wrong muscles. So let us just go through this here, ophthalmology. Right hypertropia, 4 muscles could be weak. What were the 4? But this time, we made it worse on gaze to the right. Now these came back to life, and we make the tilt worse to the left. When I tilt to the left, the right eye has to excycle toward, and the left eye has to. So you have to do that, otherwise your whole world would tilt like this. So in order to keep your world straight up and down, your eyes have to do this. That happens automatically. It's a reflex called the vestibular ocular reflex. You don't notice it, but it happens every single time. Every time you tilt your head, this is the windshield wiper. Okay, so what's the answer? So you got to show your work. Right hypertropia, 4 muscles. It was worse on right gaze, you're down to. But it was worse on tilt to the left, which means right extorter or left. Okay, who wins? Pick.
Right inferior.
What is it? Tilting?
Right hypertropia, worsen right gaze and left tilt.
Yeah.
Okay. Yeah, not very oblique.
No,
Not
you cannot pick muscles that are not playing.
Yeah.
Right?
Yeah.
Saudi Arabia, they lost in the second round. Yes? Cannot pick them anymore. Okay. One more time here. Right hypertropia. 4 teams are playing. Saudi Arabia, Qatar, Kuwait, Bahrain. Yes? Second step.
Worse in the left gaze.
It was worse on gaze to the
Right.
Right.
to the right.
Yes.
So it's gonna be inferior oblique.
Always say the side first. No more Saudi Arabia. Okay, you cannot pick that team anymore. It's Qatar against Kuwait. Okay. Last step.
Left hand tilt.
Okay. Right eye has to extort or intort.
Right eye.
Extort. Left eye has to. If you don't do that, the whole world will tilt like this. You sure you got this?
Yeah.
All right, let's change it back to right tilt. Right hyper, right gaze, right tilt.
The left
Cutter one. Kuwait one. Cutter. Kuwait. Kuwait. Yeah? If you don't get the right superior oblique on the 3-step test of right hypertrophy, you should already be thinking it's skewed. You understand what I said? Having an isolated left inferior oblique or an isolated right inferior rectus muscle is so super rare. It's either myasthenia gravis, there's something wrong with that muscle, or it's skewed. Those are your 3 choices now. You understand what I've told you about this 3-step test? None of this will make sense unless you know what this 3-step test does.
Can we
Yes.
repeat the third step? How can we choose the muscle?
Repeat the 3rd step.
Yeah, please.
Okay, ophthalmology, tell me the 3rd step again, but you gotta show your work this time. Right hypertropia, 4 muscles.
Right inferior.
Because those are the depressors of the right eye. If you ding out the depressor, it'll go up. Because it doesn't have to be a right hypertropia, it could be left hypotropia. Left hypotropia. It's worse on gaze to the, if it's worse on gaze to the left, However, I changed the last one, make it left tilt. When you tilt the head to the left, the right eye has to.
Extort.
See, she doesn't get that part. You have to explain it to her now.
The left eye will, if you have tilt to the left eye will have to insert.
Intort.
And the right eye extort.
If you don't do that, your eyes will stay like this.
So what if the intorter is weak, which is the left eye is intorting, will be the left superior left.
No.
The one that's not
No.
The one that's not intort.
means the piece that have high left eye, not high.
Right hypertropia, worsen left gaze, and left tilt.
Left superior.
Yes, you tilt to the left.
You tilt to the left. Your right eye has to do what?
Your right eye will have to intort.
Has to intort. If it doesn't intort, your world will tilt. And the left eye has to?
Stop.
Okay. But don't pick teams that aren't playing. If it's right hyper, left gaze, and left tilt this time. Okay, what do you get for this one? These first four teams.
Right superior left, right superior left, left superior left.
Second step, left gaze, left.
Left superior
Left
rectus.
superior left.
Right superior. Right
Right
superior.
superior.
Okay, you're gonna be wanting to pick Kuwait now, right? Because you just love Kuwait so much. You the fourth, it's a superior play, Kuwait, go Kuwait. But it was the wrong side. It left. And when you tilt your head to the left, the right eye has to
Extort.
Okay, how to intort?
extort,
In-
intort. But I only have two choices.
Intort.
Left superior.
Who wins?
Left superior.
And if you get that, you should pick skew. It doesn't matter how much you love Kuwait. They didn't win. They didn't win. You understand? Because ophthalmologists always pick Kuwait. They will pick fourth nerve palsy on this every single time. Kuwait, Kuwait. They're not playing anymore. They lost. Yes? What if you don't get Kuwait? You skew. Or myasthenia. Or there's something wrong with the muscle. You don't know what this is yet. You have to keep working this up. Do you understand how this three-step thing works? All right. How are we going to measure this torsion?
Double mat.
Double Maddox rod. What is a double Maddox rod? What is a double Maddox rod? Who wants to tell me what a double Maddox rod is? What is a Maddox rod?
The glasses with the red eye ready glasses. Right eye ready glasses and the left eye is green.
No,
No, no, that's dual chromatist. That's dual chromatist.
So a Maddox rod is a series of cylinders. Okay? See, these are little cylinders. So this is a lens, not a prism. Okay? So a prism takes light and deflects it. So a prism is what we use to measure misalignment. So that is called a prism diopter. So a prism diopter is the unit of measure measuring the centimeter of displacement of light by this optical device called a prism. You with me on the prism diopter? Lenses are not prisms. Lenses just have diopter power. So a lens focuses light onto its focal point. So I have glasses. These are lenses. They focus the beam because I am nearsighted and I have astigmatism. No prism. So there's prism diopter, that's the measure of a prism, and there's diopter, which is measure of a lens. The Maddox rod is a cylindrical lens. The reason we have cylindrical lenses is when you have a lens, if it's a sphere, its power is the same in all meridians. So I am a -7 sphere because I'm a myope, and that means my image is formed in front of my retina, and I can't see. So I need a diverging lens to bring the light onto my retina because my eye's too long because I'm a myope. That's -7 sphere. But I also have astigmatism, which means in one axis, I can't see as well. So the light, one of my axes is in front of the retina and one is on the retina. But I cannot use a spherical lens to fix that because only one axis is out of alignment. And that thing is called astigmatism. I have regular astigmatism, regular. And that means I can fix it with glasses. So my prescription is -7 sphere plus 1.50 times 0. So I have an astigmatic lens. I have a sphere to move my myopic prescription to put the light onto my retina. But one of my axes, which is this axis, needs to have a separate lens called a cylinder to correct my astigmatic error. You with me on all of that? So if you have a series of cylindrical lenses, this will take this light source and make it into a line like this, 90 degrees away from the axis of the cylinder. So when we put this double Maddox rod up, the patient, we shine a light, they see a line like this. And because the two things are different colors, this one's red and this one's white, if they have a hypertropia, they'll see a red line and a white line like this. And because it's making a line 90 degrees away from the cylinder axis, that when they have torsion, they'll see this. Torsion. So then you tell them to dial this little thing and it moves this little cylinder and then it'll straighten up like that. So you'd say, turn this little knob until you can make them parallel like railroad tracks. So then they go like this. And that measures the torsion. So what will be the torsion if it's a right superior oblique palsy? If the primary action of the superior oblique is in torsion. What will be its X cyclotorsion? So we better measure 5 degrees or 8 degrees or some degree of X cyclotorsion in the ipsilateral eye to the right forefoot on the double max. You got all that concept down. So you need to know 4 things already before we can even start to talk about the skew. Like we haven't even talked about the skew yet. You just need this information to get to what the hell is skew. Okay. Number 1, you have to know what a 3-step test is. Number 2, you have to know the primary, secondary, and tertiary action of each of these muscles. Number 3, you need to know the difference between X cyclotorsion and in cyclotorsion. And number 4, you need to know that the double Maddox rod is a cylindrical lens and it'll make 2 lines, and that's how we measure the torsion. You got all of those concepts down first. Okay, now comes the skew. So you do the 3-step test. And it doesn't produce Kuwait. He's like, I wanted Kuwait, I wanted it to be a 4th, but they didn't win. And I think it might be tough. Might be Saudi Arabia though. Might be Bahrain. I don't know. We gotta test it. Do the torsion, and what you're looking for is it bilateral or not? So when you have, remember this whole tilt your head thing? What nerve is providing the input for your head is tilted? Remember that nerve? What cranial nerve is this? 8. But not the hearing part of your nerve, the balance part. It's the name of the reflex that it's doing.
BOR.
BOR, the vestibular ocular reflex. You don't have to think about it. When you tilt your head, it just rotates the other way, whether you like it or not. So when you tilt your head, you'll be sad if you don't have counter rolling the other way. So because there's BOR, you're happy. This is to maintain the vertical alignment of your visual axis. You got all that part. All right, what if you have bad signal here? Central otolith misprocessing. Then you'll get the signal that your head is tilted, and it's not. And then when you get that signal, you'll have counter rolling the opposite direction to compensate for a head tilt that you actually don't have. So your brain thinks you're tilted like this to the right. There'll be counter rolling and a hypotropic eye. So this is what will happen. The ear, not the peripheral part, the central otolithic connection, central vestibular system, somewhere between cranial nerve 8, 6, 3, and 4. 3, 4, 6. That means skew can be anywhere inside this box. You have no idea where this lesion is. Yes? Skew just means posterior fossa somewhere. You have no idea. You also don't know which side it's on because this 6th, it's receiving the input from the 8. It has to send the information up the MLF to the most rostral portion of the MLF, the rostral, medial, interstitial, longitudinal fasciculus, to the vertical gaze center at the thalamomesencephalic junction. So what you get when you have a skew is you have this faulty signal. It makes you think your head is tilted, but it's not. Then compensatory head tilt, the opposite direction. So you think you're tilting to the left, and so then you're tilting to the right to compensate for this non-existent head tilt to the left. And then you have torsion like this, and then you have hyper. But it really is a hypo. So you'll have hypotropia plus a bilateral torsion towards the ipsilateral hypotropic eye. Plus, you'll have a head tilt, which we call the ocular tilt reaction. So, it'll look like this. Person's head is tilted to the left eye is down, and both eyes are towards the left eye in a left-sided skew deviation. So you got all that. All of that was caused because the otolith is giving the faulty signal right here. But you don't know whether the faulty signal is here or here or here. If the lesion is above the level of the pons, it's actually on the other side. And therefore the skew, it's not localizing. It only tells you posterior fossa, it's not lateralizing. You don't even know which side it's on. So skew, it's a vertical deviation. You do the 3-step test, you didn't get to Kuwait. It was not a superior bleed. You did the double Maddox rod testing. You're supposed to be excyclic torsion, and this instead you got bilateral torsion, and everything's towards the hypertrophic eye. This is called skew deviation. You need to scan. Could it be myasthenia? It can always be. So before you call anybody skew, especially in isolation, you gotta rule out myasthenia. Could it be the muscle? Yes. Could it be fracture? Yes. Could it be thyroiditis? Yes. There's no way for you to know. You have to scan. MR, head, orbit, delineate, that's it. Luckily, skew is defined by the company it keeps. So when you have a lesion in your brainstem, usually you have other findings. So the most common thing that we see is I&O with a vertical deviation. That's skew. You with me on the skew? Oh, I have vertical deviation and my arm is paralyzed. This is skew. I am weak on this side. This is skew. I have a numb on this side. Skew. Yeah. It's defined by the company it keeps.
So it's like a rupture.
Hmm?
It's like a rupture. It's not like a diagnosis.
No.
Just a rupture.
It's a vertical deviation that cannot be explained by single muscle or muscle groups and is defined by a lesion in the posterior fossa and by the company it keeps. However, you should suspect the skew from the start if your 3-step test doesn't generate Kuwait.
And
Right superior bleed.
there is something about when you lie down.
Okay, so when you lie down. So there's 3 steps, right? But there's actually 5 steps. There's 5 steps to the 3-step test. The first 3 steps are, number 1, which eye's higher, primary gaze. Number 2, is it worse on right and left gaze? Number 3, the head tilt. If you do those 3 and it comes up Kuwait, you're done. Fourth nerve palsy. You do the double Maddox rod testing, there better be excyclic torsion in the ipsilateral line. If you get, that's the 4th step of the 3-step test. However, there's this 5th step, which is the lie down thing. If you lie in the supine position, the otolith feels it. And therefore, what will happen to the skew if you lie down? It'll go away. But what if it's fourth? The fourth doesn't care whether you're lying down or not. So the only one that's positional is skew, because that is VOR. And if you're lying down in bed, there ain't no VOR, because you're just lying there. The VOR is for this. Get up, turn your head. Lying down in bed, there's no VOR. That's why dizzy people actually feel better. They're like, yeah, I feel better if I just lie down. Don't move my head. I'm fine. As long as I don't move my head. What if they go like that? The beep, 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 beep. You know? So otolith and semicircular canals care. But you can put the otolith to rest if you lie down and don't move your head. And if you do that and the deviation goes away or is less, that's skew. The fifth step of the three-step test. You got all that?
Then you have to scan.
You have to scan it. So if you do the three-step test and you didn't get Kuwait, you have to scan it. You have to scan it.
The scan from the beginning.
You could, but I don't scan isolated fourth node palsy. So it quacks like a duck and looks like a duck and flies like a duck. And right hypertropia worse than left case, right tilt, and 5 degrees of excyclotorsion in right eye. Quack, 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 quack. Don't scan. You got this skew thing down? That was super complicated. I hope you got that. Trying to look a little bit blank there. If you don't remember, just come watch it on YouTube. Usually it takes 4 or 5 viewings of that to get it. You can't just get it like me just talking. All right, what else you got? Whenever you know. I don't know. I'm not convinced you got this. So let's do the hyper thing again. This time neurology volunteer. Who wants to volunteer?
I think I'm the only neurologist.
Okay. Left hypertrophy. 4 muscles. It could be that the left eye is higher, but it could also be that the right eye is lower. We call that a hypo. If it's the left eye that's higher, that means the depressors of the left eye are weak. Can you name the depressors of the left eye?
Left inferior rectus.
The left inferior rectus muscle. Left superior oblique. That's weird because the superior is actually a depressor. That's why the superior is at the bottom here, even though it's on the top of your head. But it could be that the right eye is low. If the right eye is low, that means the elevators. Right, superior rectus. 4 teams enter the championship round. Saudi Arabia, Qatar, Bahrain, UAE. If the left hypertropia is worse, when I look to the right versus the left, 2 of these muscles disappear because it's worse on right case. Which 2 muscles disappear?
Right inferior oblique.
Adduction of superior oblique, left superior oblique.
This one's still good. This
Yes.
one's goodbye. And then this side.
The right inferior peak would be out.
So now you're down to Kuwait
Rectus
and Qatar. All right. It's worse on tilt to the left. So if I tilt my head to the left, my right eye has to extort, and my left eye has to intort. That's what that means. Intort, extort. Windshield wipers. Who wins?
Left superior peak.
Because both the superior oblique and the superior rectus are both intorted. And there's only one winner. Wait. The 3-step test. However, we're going to do the 4th step. Double matic stride. What would it show in the left superior oblique? Encyclotorsion or excyclotorsion? Excyclotorsion, it has to be less than 5 to 8 degrees. If it's more than that, it's bilateral. And the 5th step, lie down, supine versus sit up. It's going to be the same. or less. If it's a fourth.
It's the same.
It's the
It's
same.
the same.
Excuse this.
Do you understand everything about this? Yes.
For double Modox rod test, in this case, if the patient is putting the red glass on the right eye and he's looking at two lines, the white and the red, which eye is the hypertrophy? How can I left? So he will see the white line below.
Why? Shouldn't left hyper the line be
Yeah,
higher?
it's confusing.
Okay, but why? Yeah, go ahead. when you look up or you look down, yeah. Here's your phobia. The light is actually hitting the opposite side of your eye. Yes. So in the retina, everything's upside down and backwards. So remember I told you superior retina cause what kind of field defect? That's weird, don't you think? And what that means is if your left eye is higher, the light, and therefore you see it even though your eye is higher. So if your left eye is higher, the light is hitting your superior retina, but you see the image down.
So the line will be below.
That is correct. So they'll see two lines like this. The one that has the left, which is the white, will be tilted. And they have to turn that little knob up and get it straight. You got it? The double Maddox rod test. Sure you got this 3-step thing down? Super difficult. All right, so as a neurologist, you need to carry around the Maddox rod because there's no way you're going to be able to do this because you don't have any prisms. So you just take the Maddox rod and you put it over their right eye, and they'll say this: "Do you see a red light and a white line?" They'll see a red line and a white line. It'll look like this. They see the line, the red line, because you put this Maddox rod over their eye. They see the line above the light. That means that's, if this is the right eye, that's a left hypertrophy. And then you just say, okay, look to your right and look to your left. Is it worse when you look to your right or your left? It's worse when I look to the right. And then you tilt your head, left and right. You're done. That means you can do the 3-step test with that Maddox rod in about a minute. You say it's a left hypertrophy, worse than right gaze and left. Final diagnosis, left fourth. With a single Maddox rod. It's just so fast.
Consult ophthalmology.
You could try, but ophthalmologists hate the phobia and they hate all of this. So they might harm you. So you better make sure they're doing the 3-step test. All right, do you guys have any questions about this 3-step thing? Skew, this VOR. It's so important that you know about VOR, by the way. And in the emergency room, that thing is called HINTS. Who wants to tell me what the HINTS is?
Hence, catch up support and sadness.
Yep.
And
So
cover and cover test for the skew.
that's right. So that is HINTS, HINTS. So the person's, you're going to get called to the emergency room because they're dizzy. They're trying to figure out, is it peripheral, and they're going to let the person leave, or central, they're going to admit them to the stroke center. They will have already had a non-contrast CT of the head. It's almost certainly going to be normal. And now the whole case comes down to whether you did HINTS or not. So the first thing is called head impulse. So we take their head and you go like this, like doll's head, except you're doing the rotating. And if it's the peripheral vestibular system, when you do that, there'll be a catch-up saccade. That's peripheral. What if it's normal? That's already bad. That means it's central. The nystagmus. I told you the forms of the nystagmus that are dangerous for central. What are the forms of nystagmus that are dangerous? If it's purely vertical, upbeat or downbeat, or purely rotary, or if it's bidirectional horizontal. That cannot be the horizontal canal from the semicircular. And now you learn the last thing, which is the test of skew, because the peripheral cannot cause skew. It's a central thing. Told you it's inside your brainstem or your cerebellum or thalamus. So every person in the ER needs the HINTS test. Head impulse test. If it's normal, that's bad, central. Nystagmus, downbeat, upbeat, rotary, all bad. Bidirectional, horizontal, those are all central. And you're going to do the cover on cover test. And if you have the Maddox rod, you're going to bring it and say that this 3-step doesn't match up to anything. And you will have said, we're not discharging this person. You do the MRI, and it's you say.
If just on inspection, they don't have hypertrophy, if I do the hands.
You can't use the inspection. You have to do a cover on cover test.
If there's not.
It'd be better if you had the Maddox rod, because the cover tests sometimes they're not so good.
I never saw skew deviation with cover.
Yeah, because it's usually a small deviation. It's just way better. Also, neurology, it's you have no prism, you have nothing. Even ophthalmology, they're not bringing the prism to the emergency room. They're not. Because those are locked up in their clinic somewhere, and they're like, hey, where's the prism? I don't know. Their call bag, it's like got drops in it and stuff. They have no prism inside there. Even if they had the prism, they wouldn't. Half of them are lost. They're missing or whatever.
Full open, open.
Yeah, that's what they say. So don't do that. All right. Few more. What else you got? Because it's whatever you want. Whatever you ophthalmology, what do you want? So here's what we've done so far. Field, we did supernuclear, internuclear, we did pupil, anisocoria. There's very few things we can do. But this is for you to pass your board, by the way. In the United States, what do you think the pass rate is on our written and oral qualifying exam for the American Board of Ophthalmology? It's 75%. 1 in 4 of my residents did not pass. 1 in 4. Is it because they weren't smart? No. How could that be? They're smart. Their test score wasn't good. There's no way. It's not a testing thing. Yes, it's thinking. It's not knowledge. The knowledge is in there. You just don't know how to apply it, or it's stressful. That's what happens. All right, what you got there? Cards coming.
I have a question about the diplopia image. So the fake image and the true image. I mean the diplopia, double vision. Sometimes on our consultants say if you close this eye and one disappears, then you can localize it to which muscle just by which one disappears, the farthest one and the closest one.
Yeah, I wouldn't rely on that at all. So,
So there's no trick.
first of all, they're both real images. So when you have ophthalmoplegia, both images are real. One eye is just looking at a different target, and one eye is fixing. So one eye is fixing on a target, and the other eye is fixing on a different target. But both images are real. They're both real images. So the first thing you need to do as a neurologist is it monocular or binocular. However, the question that they teach you to ask, it doesn't work to differentiate these two. What's the question they tell you to ask? Does it go away if you cover one eye? That's not the right question. The correct question is, does it go away if you cover either eye? Because if they happen to cover the eye with the monocular diplopia, what will they say in response to this, does it go away if you cover one eye? They'll say yes. So if they have monocular diplopia in their right eye, and they happen to cover the right eye because you asked them, does it go away if you cover one eye? And they cover the right eye and it goes away. You'll think it's binocular, but it's monocular in that eye. Okay. If it's monocular in that eye, then we put a pinhole up. Ophthalmology, you want to tell neurology what a pinhole is?
You know, it's like a small hole you see through it, central.
And why would a pinhole make monocular diplopia go away?
To different light into it.
when you have monocular diplopia, the light is hitting some refractive surface in the eye, whether it's the lens or the cornea or dry eye, and one of the images is over there, one of the images is over there, because the refraction made it hit another part of the retina. So we can block these stray lights and only let them look through the center one to get rid of monocular diplopia with a pinhole. So I told you as a neurologist, you need to carry around a Maddox rod. The other thing you need to carry around is a pinhole. But you can just make it yourself. You just take a card and you punch a hole in it. And so if the person says it goes away if I cover my right eye, if I cover my left eye, it's still there. Then you put up the little pinhole that you made by punching a hole through a card. It is better. You're done. That means not neurology. That's ophthalmology for sure. Okay? And if it's in both eyes, monocular, it's still them. The most common cause, dry eye. Second most common cause, uncorrected refractive error. Third most common cause, cataract. All right. What if it's binocular? Binocular. I cover this eye, it goes away. I cover this eye, it goes away. Now you have to do the uncover test. So the cover test is a test for a manifest deviation. Ophthalmology, what's the name of the manifest deviation? Tropia. So when we cover an eye and uncover it, and cover the other eye and uncover it, what will happen if they have no tropia when we cover an eye? Nothing.
Yeah.
They'll just be looking straight ahead. However, sometimes they have a latent deviation, and it only comes out when you break the fusion. What is the name of this latent deviation? Phoria. So those are the words you need to know. Tropia versus phoria. So phoria means your eye wants to drift, but you're keeping it in check with fusion. I have this phoria. Like my eye, it wants to drift out like this. But most time I just fuse the image. However, sometimes their phoria decompensates, and that means they have an intermittent tropia. So anything that breaks the fusion will cause this intermittent tropia. So we got three different terms: tropia, phoria, intermittent tropia. The phoria means you just have a pre-existing latent tendency for the eye to drift. Tropia means you have a manifest deviation that will be detectable with the cover and cover test. Intermittent tropia means you have to do the alternate cover test. It breaks the fusion, and then all of a sudden they have double, but then they can bring it back together. So once you've decided it's binocular, you're going to do the cover test to look for tropia. You're going to do the alternate cover test to bring out a decompensated or intermittent tropia from a latent underlying phoria. What if you do the cover test and the alternate cover test and nothing happens? There's nothing wrong with that person. What if they say, I have the double right now, and you don't see any movement? They're faking. What if you see the movement? They're not faking. Super important that you're able to do a cover and alternate cover test. That only requires your hand and knowledge. All right, but it's the same image. Yes? So the phobia is where they're seeing the image. So if they're trying to look at this tree, but this eye is pointing outwards, you need to look at a house. They're both real images. This will cause visual confusion. We call it diplopia, but really, those are both real images. All right, now, ophthalmology. You need to know which eye is fixing. Why do I have to know which eye is fixing?
Secondary deviation.
What does that mean?
When the deviated eye is fixating, secondary deviation.
Which eye is fixing?
The deviated eye.
Okay. So give me an example for sixth-nerve palsy on the right.
Primary deviation is when the left eye is fixating.
So I got a right sixth. The primary deviation is when the left eye is fixating, yes? All right, so if you got a right sixth, both eyes are fixing. But if you fix with the left eye, it's the non-paretic eye. what will happen to this eye? It will deviate. Why is that right eye deviating? Is that weak lateral rectus. So he can't abduct. So his medial rectus is unopposed. So he gets decent trouble. However, what will happen if you fixate with the right eye, the paretic eye?
The other one.
The other eye will turn in all of a sudden. But which requires more interventional effort? If you're fixing with the paretic right eye
Yes.
or the non-paretic left eye.
The correct.
So if you're fixing with the paretic eye, the amount of energy that's going to take to bring the weak eye into primary is way more than if they were just fixing with their non-paretic eye. So it would be way like this. And that's the difference between the primary and the, so that's a primary versus a secondary deviation. The secondary deviation is when you're fixing with the paretic or non-paretic eye. Paretic eye primary, non-paretic eye. Okay. The reason it's important that you write down which eye is fixating, because if you don't, if you just show a picture to neurosurgery of that ET, 50 prison doctor ET, and you ask the neurosurgeon which eye is the bad eye, what will they say? They'll say, you're a dumbass, Dr. Lee. Look, that left eye is like turned in like this. However, could it be the right eye? And that means you are fixing with the paretic eye. You understand how dangerous it is? Like you walk into the room and the left eye is like locked into this ET position. You're gonna want to say it's the left eye that's the problem, yes? Okay. What will happen if they alternate fixation now and they fixate with the paretic, the non-paretic left eye, and now this eye? What will the deviation be if you're fixing with the non-paretic eye now? Is it the primary or secondary?
Primary.
Is the primary less or more than the secondary deviation? And what will you think the deviation is done? If you measured it 75% doctors on Monday, and on Tuesday, it's only 40. I know, but what will you think about the deviation? It went from 70 to 40. You'll say it's improving. Nothing happened to that person. And what if it goes the other way? It was 40 yesterday and now it's 70 today. You'll think they are. And what if it's switching eyes? Now what will neurosurgery say? Yeah, or myasthenia gravis. All because you didn't write down which eye it was. But you look and you see, ophthalmology never writes down which eye is fixed. Okay, why would they fix it the paretic eye? That's so crazy.
Dominant eye.
What's that?
Is it dominant eye?
It could be their dominant eye. It would be even a dominant eye person. It's so much effort to do this. Why would you do this? Why would you fixate with your paretic eye? But why would you do this? Just fixate with the eye that's not weak. It's just easier. I'm not trying to trick you. Why would someone fixate with an eye that has a 6-nerve palsy? The other eye's in, or the other eye has a cataract, or the other eye has a retinal detachment. They just see better in that eye. So 6th nerve is an efferent problem. It doesn't tell you anything about their vision. What if they just see better with the right eye? They will choose to fixate with the paretic eye. And therefore, you must write down. 90% of the time, you get away with it. The reason you get away with not writing the fixation is 90% of people fixate with the non-paretic eye because they're lazy. It's just easier to fixate with the non-paretic eye. But what if you don't write it down? And then all of a sudden it went from 70 to 40 or 40 to 70, or it went from right eye to left eye, where you walked into the room and you said it was left and now it's right. You're going to have all sorts of trouble. Myasthenia workup's coming, MRI is coming, another MRI is coming. Don't do that. So you need to know the difference between the primary deviation and the secondary deviation. You need to write down which eye is the fixing eye. And you need to know that some people fixate with their paretic eye because they just see better.
How can I know this one is fixing with this eye? This is the he first came to me and now he doesn't know which eye.
Yeah, you tell them, look at this target. From the start, you already know which eye is fixing, and you break their fusion, and you force them to go. But when you take the cover away, what will happen when you let them look the way they want, they'll just go back to the deviation they actually have. Yes? They will choose to fixate with the eye that's easier. But you have to force them to fixate with the other eye. How do you do that? By covering the fixing eye. And then you have to measure the deviation again. What if it's worse when they are fixing with the right eye than the left eye?
Second.
That's the secondary deviation. You have to record all that. Yes? What that means is you can't tell which eye is the bad eye by a single frame. So on the test, if you're shown a picture with a large angle esotropia like this, and the right eye is fixing, and they don't tell you which eye is the bad eye, but they ask you which eye is the bad eye, what should you say?
So I would measure primary deviation and secondary deviation.
Because you actually don't know if which eye is fixating, paretic or non-paretic eye. What if you don't say any of that and just say it's the left eye that's bad? You fail. Are they allowed to say, hey, what about the primary or secondary deviation? Are they allowed to say, hey, dummy, maybe you'd like to do a cover test? They just let you hang yourself. Yes? Which eye is bad? The left one. Fail.
And then they put another picture as the right. Now what happens?
Yeah, then you'll say, well, it switched. I'd be thinking about myasthenia gravis. You know how many times this happens to us where the neurologist cannot figure out what's going on because sometimes the right eye and sometimes the left eye, and I have to tell them this alternate fixation. Yeah, that has nothing to do with the paresis. That's just the eye they chose to fixate. Yeah. Okay.
Can someone come with both at the same time?
What's that?
Yeah, someone can come with the walker and biomarker at the same time, like because there's two different conditions.
Can someone what?
And someone come with the walker and biomarker.
Yes. So just because you have one, they're not mutually exclusive. The most common causes for you to have both monocular and binocular is that you have something wrong with your lid as well as your motility, and you got dry eye. So if your eyelid is paralyzed, you'll get dry eye. That'll cause monocular diplopia. If you have thyroid disease, they have dry eye. They often get monocular and binocular. They are not mutually exclusive. So you have to do both. You have to do the cover test, the alternate cover test, and even if they say it's still there with one eye, you still have to do the cover test on somebody to make sure their eyes are straight, because they're not mutually exclusive. Just like people with pseudotumor can get real tumor, patients with monocular diplopia can get binocular diplopia. Most common cause, thyroid eye disease. They have both. They often have both. All right. More? Thyroid eye disease? Yeah.
Can we use for tomorrow?
What's that? What's that?
Sorry for tomorrow. Can we use for tomorrow?
They're just saying they'd like to have thyroid eye disease for tomorrow.
Okay,
possible.
tomorrow, thyroid eye disease. What else?
Neuroimaging.
Neuroimaging? Tomorrow or right now?
Tomorrow.
Tomorrow, okay, tomorrow.
In the early
Because
morning.
that one needs scans, okay?
Yeah.
So there's some things where we have to have scans, like talking about neuro, I can't draw on that.
Yeah.
Non-organic functional visual
The
loss.
functional
Okay.
loss.
We can do that one right now.
Yes.
Okay, functional visual. So the first thing you need to know is we are moving away from a lot of the DSM-5 diagnosis towards this diagnosis right here, which is called functional visual disorder. And for neurologists, it's FND, functional neurologic disorder. You need to know that the DSM-5 has changed all of the diagnoses that we used to have for ophthalmology from the DSM number 4. We'll cover that in a second. But the first thing is you must prove someone is non-organic before you say they're non-organic. So it's not enough that they have a normal eye examination. You have to prove that they see better than they claim. It's not enough just to have normal eye exam. So you have to have an eye exam that's normal, first of all. And then number 2 step is prove. The most common error is doing this one, not this one. Just having a normal eye exam doesn't mean they're thinking. You must prove they're non-organic. The second thing is if they say their symptoms are transient, you cannot use this normal eye exam to prove they're faking. It's transient. So they have to have their complaint at the time you are measuring them. If it's transient complaint and it's normal eye exam, that's not functional. Okay. All right. So how do you prove they're non-organic? So there's some easy ones, which is the acuity is down in one eye only. 20/20 and NLP. What's the very first thing you're going to do with the light? Shine the light. What are you looking for? RAPD. What if this pupil reacts and there's no RAPD? You're done. That's it. It's faking already. Yes? All right. The problem is not that one. That one's so easy. In fact, NLP, light perception, count fingers, hand motion, all of those have to have RAPD. The one that's hard is when this eye is only like 20/80. You might not. It might be hard to find the RAPD. It might be the trace, or it might be little, or it might not be visible at all. Okay. And there are lots of things that cause you to be 20/80 that have no RAPD. Epiretinal membrane, macular holes, cystoid macular edema. They're not faking. So you have to do OCT of the nerve and macula, even if your eye exam is normal. So nerve and the macula. Okay, what if the OCT of the nerve and macula are both normal? Well, now you've got to prove this person's. So not only does the eye exam have to be normal, you have to do a visual field, you have to do color vision, and you have to do OCT. So these are what I mean by you have to have full eye exam before you say something's fake. All right, 20/20, 20/80. How are we going to prove this person can see better? You're going to do that pinhole, because that's going to get rid of all those refractive things, yes? But they're still saying 20/80. So the test that I use for this scenario right here is a vertical prism, 4 base down. So if we put this prism 4 base down over this eye, the prism, it deflects the eye. But we're going to put it over the good eye or the bad eye? Over the good eye. You have to tell this person you're going to test it for the good eye. You have to tell this person that this is a prism, it bends the image, and you put it over their good eye, and they are looking at the 20/20E like this. What will be the organic response if they really are 20/80? What will they see when you put the prism over there? How many E's will they see? If they are really telling the truth, they'll just see 1 E. However, because you told them I'm putting a prism over your good eye, it's going to bend the light, they think that they're going to see 2. And so if they say, I see 2 E's, 1 on top of each other, oh, test is over. And not only that, you know exactly what their acuity is in their other eye. What is the acuity in their other eye? It's 20/20. So this test takes about 10 seconds. So 20/20, 20/80, I'm going to test you with this prism. I'm going to put it over your good eye. A prism, it bends the light. I just want to make sure this prism works. I'm going to put it over your good eye now. This is your good eye, right? And you put it over there. Then you say, what do you see? I see 2 E's, 1 on top of the other. That test is over. They are non-organic. You understand what I'm saying? And then they might say this, aren't you going to test my bad eye? And I say this, that won't be necessary. Because what I'm telling them is, I know that you are faking. But what if they're not faking? They're a conversion disorder. It'll have no impact on them. But I say it to that person anyway because I want both the conversion disorder and the malingerer to know that I know that they're faking. The conversion disorder person, it will make no impact. The malingerer person, they might stop doing it. The second thing that we got to do is if their vision is bad in both eyes, like NLP in both eyes, or count fingers in both eyes, that one we use the OKN drum. So we spin the little OKN drum. If you really can't see, when we spin that drum, nothing will happen. So you have to spin it. And if it works also in one eye, people NLP, because you cover the good eye of the sun. So you're spinning the drum. If you cover the good eye, the eye will keep jumping if they're faking. And then we've got the visual field. The most common visual field deficit that people claim is what? No, cloverleaf, that could be real. Okay, cloverleaf just means they didn't do the test properly. So in a cloverleaf field, the very first 4 points in a Humphrey visual field are tested in first minute. But then they put the clicker down, and you end up with this butterfly cloverleaf thing because all the rest of the field became black. This cloverleaf thing doesn't mean you're faking. It just means you didn't do the test properly. The most common cause of that is you fell asleep. They would click, 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 and then the rest will be. So that cloverleaf thing needs to be repeated. The most common field for non-organic is actually a constricted field. 5 degrees, like a little 5-degree or 10-degree island, like a tunnel. Yeah. So the first thing you need to know about this tunnel thing, tunnel has an entrance and an exit. In a tunnel field, it's 5 degrees at the entrance and also at the exit. So we're going to test this person at 1 meter and 2 meter testing. What should the field do if it's organic? It should increase in size. Why does it increase in size? The what? Okay, so in circles, we have to use arc in degrees. When you're measuring a line, you can just measure it. But in circles, the name of this is called arc. It's in degrees. 360 degrees is a circle. So the arc subtended on your retina is a constant. But what's differing when you increase the distance is the circumference of the circle that you are measuring. So if you're testing someone at 1 meter and 2 meter testing, even though the arc subtended on your fovea is the same, the visual field angle is bigger. You with me on this?
Yes.
And that's a funnel, not a tunnel. So if we test someone at 1 meter and 2 meter and it's still 5 degrees, they're faking. It has to expand. And that means we can see our sun on our retina. The sun is humongous, but because it's 93 million miles away, the whole sun fits on your retina. But if you're standing on the sun, you can't see anything. You with me on this arc subtended?
Yes.
Okay, what that means is please don't write tunnel field on people who are organic. Who would do that? Red. End stage RP with tunnel field. You literally wrote they are faking. End stage glaucoma with tunnel field. Don't write that. Tunnel means you're faking. Funnel is what you meant to write. A 5-degree end stage glaucoma patient will have a 10-degree field if you double the distance. You with me on this? Tunnel. Don't write that unless you mean tunnel. Tunnel is faker. Funnel is real. So we test at 1 meter and 2 meters. The other thing we do with this constricted field is I'd say, okay, now we're going to test your eye movement. Does it hurt when you move your eyes? They always say yes. So you say, look at my nose, look at the pen. And they're going to say, I can't see it. You have to say, look directly at it with your center vision. Look at the pen. Look at my nose, look at the pen. My nose, look at the pen. What should be the organic response if you really only have a 5-degree field when I put the target in your blind field? They'll move their whole head, or they'll say, when is the test going to start? So here's an organic response. Look at my nose, look at the pen. What pen? You need to look directly at it. Okay. Use your center vision. Okay. Okay, look again. Okay. What if they straight to the target? Same thing with kids. Like if my resident is testing a kid, they'll come out of the room and they'll say, Dr. I couldn't test the field on this guy. I'm like, why? He kept looking at the finger. I'm like, what? It's like, yeah, I'd say, how many fingers am I holding up? He kept looking at it. I said, look at the fingers. Put it up there. He kept looking at it. I couldn't get him to do it. I'm like, you already tested the field. You're done. So if he looks directly at the field is intact. How did he know to go up there? Yes? If he kept looking directly at the finger, that means you're done. Yeah? How many fingers do I have? Hey, don't look at the finger. But he's a kid. He's not going to listen. Okay? You're done. You tested the field. Yes? It also works like this. Just tell me when you see my finger. They have a 5-degree field. Yes. Yes. No. That no answer is a yes. You understand?
Yes.
What should they say when I put the thing up there? Nothing. They should say nothing. Yes, 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 yes. They should say nothing. What if they say no? Liar. Okay, we got all these how to test people things. So saccades, 1 meter, 2 meter, and the base down prism, and the OK. Yes.
How would you test the 1 meter?
How do we test at 1 meter and 2 meter? Okay. Come on up here. Yeah. All right. Make a real field that's 5 degrees by putting your thing like this in your eye. Okay, you ready? Say when. What? Say when you see my finger. Yeah, you have to say yes. Yes. Okay. Yes. Okay, see, he's got a 5 degree field. Yeah, that's real because he's covered. Okay. So you didn't do it.
Yeah, I see.
How many? You see his field. Okay, the faker version. You see my finger?
No.
He would only stay here if he was faking. It would be, oh. All right, you ready? Look at my nose. Look at my finger. Go do it. Go do it. Look at it. Go find it, man. Go do it. That's organic. But if he looks directly at it, he's fake. But you saw what he did when I said, look at the finger. He's like, he didn't do anything because he doesn't even know anything's out there. What finger? You understand? How to test at 1 meter. 1 meter, 2 meter, also the saccade testing. It's very fast. So this last bit is DSM-4 versus DSM-5. Who wants to tell me the DSM-5 diagnoses that we have when we were faced with dysfunctional vision? So you get to the end of the test. You already did an eye exam, OCT, nerve and macula, it's normal. You did the 1 meter and 2 meter thing, and they're clearly not telling the truth. Or you did the base down prism. Now you have to talk to me, okay? I will answer, and then you give me what you think the diagnosis is. Because in the DSM-5, what they have done is they have moved towards disorder. Disorder. Everything is disorder now. Because they're trying to remove the artificial separation between mental and physical. So we have somatic symptom disorder, which in the DSM-4 used to be somatoform disorder, somatization, and somatoform disorder, and somatoform pain disorder, which were all these different diagnoses. And you had to have one GI, one sexual, one voluntary. They just got rid of all of that. So all of these became condensed down into somatic symptom disorder, SSD. The conversion disorder, that stayed, but now we call that FBD. This person is non-organic, but they're unconscious to this thing. They're not doing it on purpose. This person here is all about the symptoms. Symptom, 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 symptom. If you fix one symptom, they'll just come up with another one. What about this? They're the what about people. Hey, good news, we don't see anything wrong with your vision. Yeah, but what about my eye pain? Well, you know, your eye pain, I don't see anything causing your eye pain. Well, what about my headache? What about my arm? What about my leg? It's like, because they're all about symptoms. This person, if you tell them that you didn't find anything, they're so relieved. Or they might say nothing. Because they have unconscious, unresolved psychological conflict that's manifesting in a somatic way. But it's unconscious. And then this thing used to be called in the DSM-3 hypochondriasis. That's called illness anxiety disorder now. So in this person, they're anxious about illness. So they're like, is it, people? Is it going to kill me? Is it going to blind me? And they'll just keep asking you over and over and over again. They might ask you 3 or 4 times, is it going to blind me? Is this going to kill me? Because they're worried about what it means. They're not perseverating on the symptom. They're worried about what the symptom means. And that we used to call hypochondriasis, but we don't call it that anymore. So that went away. Another thing that went away is this one. This went away in the DSM-3, hysteria. Who knows what this root word means? Hysteria. It's uterus. And the reason it was the uterus is the people that wrote that DSM-3 were all men. And they thought, don't ask me why they thought this, but dudes in Austria thought that only women could become hysterical. And that it was the wandering uterus, the unfulfilled desire from the uterus. It's all hooey, okay? So do not write this in people's charts. Hysterical field, or the don't get hysterical, or don't. This means your uterus is trying to blind you. Don't do that. So that thing went away. Okay, that went away. That one also is just that easy. There's no wandering uterus, all that Freudian stuff. None of it's true. Young, Freud, none of it. Just forget about it. Okay? And then you have malingering. That stayed in both. Malingering requires that you have secondary gain. It's required. All right, so you see the differences in the DSM-4 versus the DSM-5. Number one, they switched to disorder. Number two, we no longer use this hypochondriasis. By the way, hypochondriasis, it means hypo means under, chondro means your rib cage. So people used to have unexplained belly pain because their uterus would go under there and punch them in the gut. So we don't use any of those. So hypochondriasis, hysteria, somatoform, somatization, all those went away. So now I'll tell you that they all have the same eye exam, normal. They all have the same results that prove they were non-organic. And now you just have to differentiate between them. So at the end, when you're telling the person, hey, good news, you didn't find anything bad, your eye exam is normal, we think you see better than your vision looks like on these tests. What about this? What about that? That's SST. Okay, doc, whatever you say. That's the FBD conversion. Is it going to blind me? No. Is it going to kill me? No. But it could blind me, right? No. But it could kill me, right? No. It's not going to blind me, is it? No. After you tell it to them 4 times, they'll believe you, or they won't. They're the, is it going to blind me? They're worried about that. This person right here, at the very end, they're going to ask you for something. Sign this form. Fill out this paper. So I'm disabled, right? What if they don't ask you for anything? Then how could that person be malingering? They didn't ask you for anything. So you have to have an ask here in these malingering people. What if they just say, okay, goodbye, and you're done? All right, so then the question is, should you send this to psych? If they want to go. I tell them, look, the good news is we didn't find anything, but there are a number of things that could be causing this. What do you think is bringing this up on? And if it's this person, they're just going to go straight to the forms. Fill this form out. I can't work anymore, whatever. If it's this person right here, they're going to say, I don't know, but it's been going on for years and I've been to 1 million doctors and I just want to know, is it cancer? They just totally reveal themselves. This person right here, when you say what brings it on, they might say something. Whatever they say, write it down. You know, doc, it has been tough since I lost my mom. That was last year. Oh, tell me more. Then you have to be like psychiatrist for like 5 seconds. What did you think? How did that make you feel? Don't spend no 50 minutes with this person. You're just trying to get them to say what they brought it on, and then you say, would you like some help? If they say no, you're done. If they say yes, then plug them into the available services. Yeah? So I asked them. This person right here is the what about person, but they often say, you know what I really think made this happen? Insert whatever they say. You know, we can't fix all of your symptoms, but maybe there's some things we can do to help you deal with those symptoms. Would you like to see someone? It's always about would you like to, not you're going to go to psych. What if you tell this person they're psychiatric? They might punch you in the face. Okay, so if you tell this person they're psych, they're definitely going to punch you in the face. If you tell this person they're psych, they might say, you're not helping me. None of these people it helps to say you're psych. None of them. And you're not trained as a psychiatrist. So you probably should not be making any DSM-5 diagnoses in any of these people. Your job, prove that they see better than they claim, prove that their eye exam and OCT is normal, and then just ask them, what do you think about this on, and if they want help, and that's it. You understand what I usually do with these FDD people? Most people with FDD already have seen psychiatry, except this person. You understand what I've said? As soon as they say, no, I haven't, I know exactly. You guys have any questions about FDD? Soon everything is going to move to FDD. Everything. We used to have to try and delve into their deep-seated psychiatric conflict of why they had this. We don't do any of that. Yes.
So the patient says, I cannot see at all, okay? And I do an OKN test and it's positive. That means they can see.
That's correct.
At least 400 right?
That's right. So that's the easiest. The bilateral or unilateral, it's completely blind person. That one's so easy. As soon as you swing the light, no RAPD, and now you do the OKN, you're done. And that's the person I say, you know what? There are a lot of things that can cause this: stress, lack of sleep, foods and drinks. What do you think brought this on? And they either share or they don't share. And if they're malingering, they'll say something like, it was after that accident, and can you sign my paper?
You know, what I do sometimes, I do like the scissor chart, I put the big one first. So wait for the small one first. So this one, and sometimes it works. Sometimes.
Yeah, and there's all these different versions of that. The problem with doing those kinds of things is the patient immediately knows you're trying to trick them. If they have, and as soon as they figure out you're trying to trick them, they get upset. So I always start with tests where they don't know how the thing works. That prism thing, nobody knows how that works. The 1 meter and 2 meter thing, they never know how that works. Move your eye, just, I know it hurts you, but do your best. They never know. So I always pick the ones they can't figure out. There are all these other ones, like the stereo and I mean, there's all these other ones where you're trying to trick the person, like fogging and trying to see it. The people who are smart can figure it out right away. And if the malingerer knows that, it's going to be a big problem because they will stop cooperating. As soon as you do any kind of tests where they can figure out you're trying to trick them. And the problem is when they do the close the eye thing. So you should be looking out for that one. If they do the close the eye thing, you got to say, no, I'm trying to test your good eye with this. Okay. That's why that test works so much better. Testing the good eye. You can't let on to the person that you're trying to trick them.
And they can use the for prism diopter with a bad eye.
You put it on the good eye. That's what's great about that test. They don't know that you're testing the other eye. Anything you do to test the other, like the fogging thing, or like put the big letter up, they already know you're testing the bad eye. See, that's the danger of doing those tests. Any test that tests the bad eye, they're going to be very suspicious of it. It doesn't matter whether they're malingering or somatic symptom, or they're just, you cease to be their advocate on that. As soon as they figure that out, they're just not going to like it. All right, well, I will save thyroid, myasthenia, and imaging for tomorrow. I will let you guys go. I hope that you learned something. Thanks so much for coming. Take care. Hope you learned something.